You are probably all familiar with the Heidelberg and Goss classification. And you're probably all familiar also with the AO classification, which is more or less following the same rules, but the reliability of the AO classification is better both inter and intra-observer, as shown in this study. Nevertheless, in daily practice, mostly we use the Heidelberg and Goss classification, so I will continue with that classification. Well, for imaging, the standard trauma series are important. If the patient is not able to abduct the arm, a Velpo view is very helpful to get information on your X-ray. But I think if you treat glenoid fracture, CT scan, and especially 3D reconstruction is mandatory. And you should ask your radiologist to distract the humerus to get a proper sagittal view on your glenoid. Well, the rim fractures, and that's been discussed widely by Marcus, are mostly due to dislocation, and the fossa fractures are mainly followed, mainly the result after an impaction, after a fall. But the rim fractures, mainly anterior and smaller number posterior, as shown here, and that's of course the numbers is related to the high rate of anterior dislocation compared to posterior dislocation. And you should distinguish a chip avulsion, which is present in nearly all labral detachment, where there is a small piece of bone always at about 4 or about the 8 o'clock position. And that is where the labrum is very strongly attached to the bone and a piece of bone is detached. But that is different from the rim fracture or the glenoid fracture. Here is a small one, but there are bigger ones leading to the same size of glenoid fractures as Marcus just showed. Well, inferior is very rare. We have seen one case, and it was displaced quite inferior. The patient refused operation, and operation is quite challenging, but the patient refused and became stable and no complaints and full range of motion without any complaint after the rim fracture. Although the triceps is partly detached and the inferior glenoid is detached, the natural course was quite benign in this case. I would have loved to operate on it, but the patient refused. Well, the treatment of the rim fracture has been discussed earlier by Marcus. If they had the center, you can remain conservative. Nevertheless, it is important during the first 6 weeks, during the healing of the fracture, to follow the patient, because sometimes after 2 or 3 weeks, there is slowly an ongoing subluxation inferior, and then you still have to treat it operatively. The treatment is either open or arthroscopic and has been described already nicely. I show a case here. My video is not there. A case where a 50 years old young guy, first dislocation right shoulder. You could consider to treat it conservative, but I thought in a young guy, it is, I think, better to operate. A little bit more simple procedure, as Marcus showed, but here is the detachment of the labrum. Luckily, the labrum is always intact. You detach it properly. The labrum is taken care of, it is making it quite stable. If the labrum is torn, then it is more challenging. I put in a resorbable anchor, a biodegradable anchor, superior and inferior in the defect, and I pass a leading suture, a PDS, through the bone or medial to the bone, and then lead the sutures outside and attach it. It's quite straightforward, a little bit different. As Marcus showed it, a knotless anchor, I use mattress sutures to fix the fragment and compress it to the remaining glenoid. Here is a small step off on the follow-up CT scan. The patient was completely stable and could do his sports again. Well, the fossa fractures type 2 to type 6, they are not so very frequent. My treatment algorithm is that if the fracture gap is larger than 5 millimeter, or if the step off is larger than 5 millimeter, I operate. The contraindications are severe comminution or when neurology is involved. There is a case of a patient who had an Heidelberg type 3 fracture. You see here, superior fracture, quite displaced medially together with the coracoid. You see the fracture extending more medial into the medial part of the scapula. I did an arthroscopic treatment. I also stabilized the coracoid, because the coracoid was involved in the fracture, connected with a button to the clavicle, and I did 2 screws, and here is the approach through the arthroscope. Normally I use the Nevisor portal as well to address, especially for the posterior screw. Sometimes you have to go through a posterior portal. This depending a little bit on the direction you have during the surgery.